is being recorded.
WHO's Southeast Asia Regional Office. So, if sir is
Yes, I am.
oh,
Okay.
sir, welcome, sir.
Thank
And
you. Thank you. So I'll start my presentation. I hope you can see my slide.
Yes, sir, it's visible.
Okay. So good morning, good afternoon, and good evening. I'm sure there are participants joining this webinar from across the world. So my topic is towards a roadmap to achieve WHO cervical cancer elimination goals in India. I had the good fortune of being part of this development of the WHO cervical cancer elimination goals when I was in Geneva. So it is good to talk about the progress now. So as you all may know, in August 2020, the World Health Assembly, that is the Assembly of Health Ministers of the world, have agreed on the global strategy to accelerate the elimination of cervical cancer as a public health problem and its goals and targets for the period of 2020-2030. So this is a landmark resolution of the World Health Assembly, which has implications on multiple sustainable development goals. Before we jump in, I just wanted to give a bit of clarity on these terms: control, elimination, eradication, extinction. People always get confused. Control is getting the disease to a certain level, which is locally accepted. Elimination as a public health problem, which is what we are trying to do for cervical cancer, is a term related to both infection and disease. It is defined by achievement of measurable global targets set by WHO in relation to a specific disease. It is not eradication. Say, even after elimination of cervical cancer as a public health problem, there will be cervical cancers, unlike eradication of polio or smallpox, where one does not expect any case after that. So just get that clarification in mind. So how did it all start? The various modeling was done on the right side. That simple graphic, it shows that straight gray line is the status quo, which the world will have about 20 per 100,000 per year, which is the incidence of cervical cancer. The green line is the vaccination only line, which will reduce it substantially like that. Blue line is vaccination and 1 lifetime screening, and the red line is vaccination and 2 lifetime screening. So in that case, if you go like that, by about, if you start in 2020, by about 2070, 2080, you will reach a target of 4 per 100,000, which is the elimination target. Similarly, for mortality reduction, just look at this purple curve. This purple curve is basically girls only vaccination, 2 lifetime screening, and cancer treatment. So that will also reduce mortality substantially compared to the other strategies of vaccination or screening alone. This is to show the impact of treatment also. So that is how the target setting for 2030 was done. To determine the threshold, WHO evaluated epidemiological data, modeling studies, considered the time frame, and set up this framework, which is elimination threshold, which is to reach 4 per 100,000 per year. That is the ultimate target. But the interim target, so 2030 is not the target. There are interim measures, milestones to moving towards 4 per 100,000, which are one, of age, and 90% of women identified with cervical disease receive treatment and care. And the SDG target also 1/3 reduction in premature mortality from NCDs. This actually plays out beautifully into a life course approach. In primary prevention, we have improvement in living standards, health information, sexual education, everything, condom promotion, along with that key intervention called HPV vaccination. So disease process has not started, so you prevent from starting. Then from 30 to 45 years, you have the opportunity to do secondary prevention. That is women with potential precancerous lesions. Disease process started, but invasive cancer has not occurred. So you identify and prevent. And if the invasive cancer has occurred, you identify it in early stages and treat properly. What is the situation in India? About 130,000 new cancer cases and about 80,000 deaths, which is unacceptably high. And the second most common cancer among women after breast cancer. And the global map, the incidence is in blue, mortality is in orange. You can see the deeper the color, the more severe the incidence and the mortality. So which is global South, Southeast Asia, Sub-Saharan Africa, South America has some of the highest rates. Let's look at one by one. One is 90% of girls fully vaccinated with HPV vaccine by 15 years of age. What is or 2-dose schedule for girls aged 9 to 14 years. A 1 or 2 dose schedule for girls and women aged 15 to 20 years. 2 dose with a 6-month interval for women older than 21 years. All that is fine, but what is most important is the next sentence. The primary target of vaccination is girls aged 9 to 14 prior to the start of sexual activity. The vaccination of secondary targets such as boys and older females is recommended only when it is feasible and affordable. So that is only after we covering the most important eligible age group, which is adolescent girls in the age group of 9 to 14 years. So that is clear. Now, is it 1 dose or 2 dose? Now, WHO says 1 or 2 doses, but 1 dose has gained a lot of momentum now. 1 dose schedule can help to increase coverage. Among countries which are switching from 2 dose to 1 dose, which many countries are doing, an 8% coverage increase is immediately seen. 37 countries have started or switched to implementation of the single dose schedule in 2023. Notable among that is England. So in the UK, HPV vaccination program has moved from 2 dose to single dose from the September 2023. So that means their Joint Commission on Vaccination and Immunization have looked at all the evidence. But in last week itself, I think in just 2-3 days back, the JMCI monographs on cervical cancer came out with a series of papers on single dose vaccination, and notable among that was the one which was carried out in India, which Partha Basu and others from IARC has done, Shankar Narayan and others. So which said that even if you do single dose vaccination, with the current incidence of about 17 per 100,000, which is in India, that alone in another 30-40 years will take us to the elimination target of 4 per 100,000. So 1 dose with high coverage can make a big impact. Again, Partha and others have written a very nice article in HPV World, which clearly says that vaccine efficacy against persistent HPV 16-18 at nearly 10 years was 95% for single dose, and 2 dose it was 93%, and 3 dose it was 93%. So hardly any difference between 1, 2, and 3 dose recipients over a period of 10 years. So their summary is that by launching the vaccination program with a single dose, India would prevent close to 1 million cases of cervical cancer in the lifetime of the 120 million girls under 10 who are likely to be vaccinated. India must be pragmatic in its strategic planning for HPV vaccine introduction. In addition to saving resources, a single dose regimen will avoid the logistic complexities of tracking the girls to administer the second dose. And introduction in the national immunization program will be a significant contribution to the global elimination targets, given that India contributes to the significant proportion of the cases and deaths to cervical cancer. So the summary is that start with single dose adolescent girls and start without delay. Coming to the second target, 70% of women screened with a high performance test by 35 and 45 years of age, which is even more complex. What does the WHO say? WHO says exactly that every 5 to 10 years to start screening from 30 or 35, ideally, but at least 2 screenings, 135 and 145 should be done at least. Okay, precancers rarely cause symptoms, which is why regular cervical cancer sometimes may be important even after HPV vaccination, but we don't have to get into that. Self-collection is feasible, which is one of the good strategies to look at. And after a positive HPV test, one can look at the cervix and then treat accordingly, either with cryocautery or thermal coagulation. This is a very old data, the NFHS of India, which is not really reliable because it's only one question ever undergone a screening test for cervical cancer in the age group of 30 to 49 years. The answer is 2%, which might have gone up to 10 or 15% now, but still far away from the 70%. But why is it that? First of all, we need to understand the amount of work that needs to be done. You take a country of population of 100 million people, okay? In India is 1,000 million. So if you take 100 million, women are 50 million. Out of that cervical cancer, let's say 9,000 are expected. Women in the eligible age group are about 15 million if you take 35 to 45. Out of that 70%, that is 10 million. 10 million women have to be screened every year. And that new women are coming into that age group every year. And if the prevalence of precancer is 5% or something like that, which is about 500,000 precancers, is your system ready? Is our system ready? That is a question to ask before we jump in. And we have to make sure that the system is ready so that we can achieve. It's a very interesting study done long back. It is actually the impact of screening in England. They have looked at the impact in different age groups, but They also modeled what happened if there was no screening. That is that long line with the dots in between, that line which is going up. Across the age group, at least in 35 to 49 and 50 to 64, the observed rate would have been almost 40 to 50 per 100,000 if England did not have screening. Imagine. So there is an epidemiological thinking that cervical cancer is very high in low and middle income countries. That is just because we don't have enough screening. The risk of cervical cancer is much higher in high income countries. It is not manifested as invasive incident cancers and part of the cancer registry data because at the level of pre-cancer, it is detected and treated so that invasive cancer doesn't occur. I think that's a very big lesson for us to learn. Even epidemiologically, one has to understand how this happened. Dr. Anuman and others have just come out with a systematic review on various aspects of HPV screening, which was again published last week. Community-based HPV testing, including self-collection, is feasible in India, with more research needed among underrepresented population. They say that implementation research is needed on integrating HPV with the existing health systems, feasibility of HPV test and treat models, and genotyping triage to improve follow-up in low-resource settings. So the summary is that we need to really do good implementation science. So screening, again, let me remind everyone, screening means among asymptomatic people, you invite a group of people by age group, then you go and apply a test. The test should be very good so that they become either positive or negative. Negative means they can be left out. Positive means you do further investigation and then treat and prevent the disease progression. So entire chain has to be thought through. What I see is that most of the time, first part of the screening program is done. Women are invited and tested, and then not much is concentrated after that. And an important part, I'm sure Abhishek Shankar and others are working on communication. I always think that at policymakers, it should be fact-based and instill confidence because there should be a unified voice at the level of policy. For program managers, you have to give full details about the program, not just bits and pieces. Implementers should do exactly how each procedure gets worked out. What is the safety and comfort? What are the complications? How it is to be done. And for potential participants, it should be simple language and no jargon. I think medical jargon will not help in any communication, especially in cervical cancer. That is why it leads to a lot of suspicion. So that means we have to really do implementation research and understand how HPV testing will work. Moving on to 90% of women identified with cervical disease, which is cervical precancer and invasive cancer. 90% of those with pre-invasive cancer and 90% of those with pre-invasive cancer should be treated. And what is WHO guidance? In a screen, triage, and treat approach, HPV DNA detection is the primary screening among the general population. Either partial genotyping, that means we can look at 1618, colposcopy, VIA, or cytology to triage women after positive HPV DNA test. In a screen and treat approach, HPV DNA detection is the primary screening test. And then all the women who are test positive for HPV DNA can be treated. But you can also add VIA. So we don't have to throw away VIA. If you shift to HPV, we can still use VIA for triaging and for treatment. And the treatment options, as you all know very well, are thermal ablation, cryotherapy, leads, and thermal ablation seems to be getting more traction these days. So how do we do with screening for India? We have to ask this question. Is our health system ready to screen cancer? National policy and program? Yes. Clear specifications on age group, test, treatment, and who should do what. How to invite women in the eligible group. What level of the health system will do the screening? We will just say primary health care, but that is not. Has anyone gone and looked what are the situations in primary health care to do an HPV testing or to do a full round of screening, including management of precancers? Do they have the personnel and testing capacity? How many people can they screen? Are they adequately trained? Where is the treatment of precancer? Where will cancer be treated? Because some cancers will be detected while you screen. Who will bear the cost? What do we do with people who are defaulters? Are there reporting system to know how many people participate in the program? And how do we know whether the impact of screening is there or not? So we have to learn by doing, screen women in organized groups, work sites, etc. Learn all the requirements and processes, then expand the general population, and screening always should include management of screen positives. Finally, management of invasive cancer, the challenges we all know very well: late-stage diagnosis, lack of access, financial toxicity, lack of standard protocols, and even palliation becomes quite expensive. Data from the National Cancer Registry Program of India shows that across hospital registries in India, only 30% of cervical cancers are in localized stages, 60% are in local regional. That means almost 2A, 2B it is becoming. So that is not good. We need to get cervical cancers in stage 1, which is going to make a big difference in survival. Also, for a woman with symptoms, sometimes it takes up to 6 to 8 months with many trips back and forth to various health facilities before definitive diagnosis and treatment is started. So early detection can cure cancer and delay can lead to death. So we have to avoid this health system complexity and ensure that navigators and others are available so that women with symptoms get diagnosed and treated early. The strategic actions are, first of all, we need to have standard treatment management guidelines for cervical cancer, very good referral pathways so that the women should not be left here and there unattended. Pathology service. Without pathology, there is no cancer service. So ensure that in every district within about 25 kilometers, a suspected person can get a definitive diagnosis of cancer. Surgical capacity has to be substantially expanded because as early stage cancers come in, we will need a lot of gynae-oncologists to do this. Improve access to radiotherapy and chemotherapy. In many places, radiotherapy waiting lists will go to months. That can be avoided because each day waiting is the tumor doubling that is happening in front of us. Strengthen and integrate palliative care services. At least initially, there will be a lot of advanced cancer cases. Workforce competencies to be looked at, cancer stigmatization, and comprehensive care for survivors. Palliative care also, Eric Rucker and others have developed very good packages for low and middle income countries. Cervical cancer, as we know, is a condition which can cause significant morbidity in terms of signs and symptoms when it is advanced. Almost every system gets affected, so a good palliative care is needed. Finally, a monitoring framework. WHO has created a monitoring framework which covers primary prevention, early detection, treatment, and end-of-life coverage with indicators such as vaccine coverage, screening coverage, adherence to protocols, test positivity rate. But finally, what matters is, as Callum Muir said, that when you have a cancer registry, you can see whether there is change in incidence, change in survival, and change in mortality. Those are the final 3 things that we'll have to depend upon. So my last slide is how do we move forward? HPV vaccination without delay, introduce 1 dose HPV vaccine to adolescent girls. Other things can come in. Let us do what we know best and what has the maximum impact. Screening and pre-cancer treatment, move to HPV-based screening very fast. Develop locally available point of care HPV testing. Screen, triage, and treat HPV positive women without delay. Start in organized groups, learn, and then expand. Treatment and palliative care, detect cancers early based on signs and symptoms, diagnosis without delay, and complete treatment without financial toxicity, and provide palliative care. Underlying this, sustain and expand population and hospital-based cancer registries, build capacity, measure, and monitor. So colleagues and friends, thank you. There are no shortcuts to any place worth going. This is looking very tough, but this is a place that we have to go, and that is the only way we can control cervical cancer. Thank you very much.
Thank you so much, Dr. Cheriambagi, sir, for this insightful lecture. I would like to express my gratitude to the chairpersons as well. Let me see if there are any questions from the audience. There are none questions. There are none for now. Let me wait for 20 seconds. If the attendees have any questions or comments, they can put it in the chat box.
I think it's great to see 107 people in just first 19 minutes. So thank you everyone for putting this efforts. So Ashwin, do we have question?
No, sir. None for now. Since there are no questions, I would like to invite Dr. Rohit Saini to deliver a special address to the guest of honor for today's program. Thank you.
Thank you, Dr. Ashwin. Hello, I am audible.
Yeah, you are audible.
So thank you, Dr. Ashwin. So the next will be a special address for the guest of honor, Her Excellency Dr. Janab Shinkafi Bagdu. Thank you, Her Excellency, for agreeing to participate in this online event. It's a great honor for all of us. Dr. Eden will introduce the guest of honor now.
Thank you, Dr. Rohit. Good evening, everyone. This is Dr. Aiden, and it's my privilege to introduce the guest of honor, Her Excellency Dr. Zanab Shinkafi Bagdu. Dr. Bagdu is a distinguished pediatrician and a global advocate for women's health, particularly in the fight against cervical and other female cancers. She's the president-elect of the Union for International Cancer Control, that is UICC, and chairperson of First Ladies Against Cancer. As a founder and CEO of the Medicaid Cancer Foundation, she has spearheaded transformative efforts to bridge gaps in cancer awareness, prevention, and treatment. Recognizing the urgent need for cancer awareness, she established the Medicaid Cancer Foundation, built on pillars of outreach, advocacy, capacity building, and access to treatment. Under her leadership, MCF has raised over $2.5 million to combat cancer. She has championed initiatives like the adoption of the single-dose HPV vaccine in 2023. As the chairperson of First Ladies Against Cancer, she collaborates with leaders around the world to advocate health policies, reflecting her enduring commitment to a cervical cancer-free future. We welcome you, ma'am. Over to you, ma'am.
Dr. Janab, see if there's someone. We just ask hello. Are you there? I'm just calling her.
Okay.
She's there, she's connecting.
Hello, can you hear me?
Yeah, we can
Please
hear
give
you,
me-
ma'am. Yeah. Is there any technical issue, ma'am?
Please allow me to find a quiet spot in 2 minutes, then I will, in 1 minute, I
Yeah,
will be able to speak clearly.
Okay, no issue. I
I'm
can
just
understand.
walking
Yeah,
back
yeah,
to
sure.
the-
Sure. That's not in 1 minute. Okay. Deepak, do you have that IGCS video ready, right? So can you please put it here? Okay. So you can take 1 or 2 minutes, ma'am. We are putting a video, on the communication by IGCS till the time you reach your office. Take your time. I can understand. Deepak?
Can you hear me? Can you hear me now? Hello?
Deepak, ma'am has already joined, so we can put it afterwards in the panel. Okay.
Can you hear me?
Yes, ma'am.
Hear you,
We
ma'am.
can hear you. Yeah, we
Can
can
I
hear
go
you.
ahead?
Yes, ma'am.
Okay. Good afternoon from Abuja, Nigeria. I'm sorry about the disruption, but it's a very busy day with so many activities, all to do with cervical cancer. So thank you for asking me to give a note, and also for the work that you're doing and the conversation. It's also an important day for us in Abuja today because we're actually hosting the Indian PM. So while my husband is there hosting the Indian PM, I'm very pleased to be with you in India. I don't have to be the PM, but we need them. And I will start by saying the things that we do in cervical cancer control are totally in line with the WHO recommendations, particularly in view of the elimination strategy of 90-70-90. The Medicaid Cancer Foundation, which I founded about 18 years ago, has been very active in the northern parts of Nigeria and at a national level in advocating for policies that will reach that elimination. If you look at the call to action for the elimination in 2018, Nigeria was the only sovereign country that was listed as a partner on the list of partners in the DG's call. And after that, that was through the efforts of the foundation and we were able to join various initiatives, particularly in my state, which is Kebbi State, a small state, but has served as a pilot and has been able to lay a lot of foundation and example for the program. The other FLAC, that is the First Ladies Against Cancer states, are about 12 in number, and they have also picked up on the vaccination, screening, and early treatment. With support from the United funded program that was implemented by CHAI in Nigeria, we were able to screen 40,000 girls in the state and a lot more around. We have an estimated, just like India, Nigeria is a high population country, and we have an estimated 30 million women to screen across 2 years before we get to 2030 goals. So it's going to be a huge task. And one of the things that we're doing now as the vice chair of the National Cervical Cancer Elimination Task Force is to try to form partnerships with diagnostic companies, with financial corporations and other stakeholders that are going to enable us have the adequate resources, train the manpower for this training. We know that in India, you have a lot of capacity. Aside from the human capacity, you also have a vaccine. The vaccine was very difficult for us to get because obviously of the price and the high numbers. But eventually we were granted Gavi support, and we've been able to successfully vaccinate as a country about 12.4 million girls aged between 9 and 14. The problem comes now in the routinization of that vaccine. It is my hope that we'll be able to build some form of conversation and start it so that we can tap into the resources that you have, namely the vaccine, the testing, the screening. I recall a time when we were offered screening kits for about $1, and I've read about the Indian make that is in the market. The other makes go for as high as $15. That is for the HPV high performance test. So I hope that after this call, we will find good partners who we can work with that will help us to have that program running fully in Nigeria. I also sit on the board of the UICC on a global level, through which my advocacy extends to publications and fellowships and so many other things that we're able to do on the UICC platform, through which we can chip into the elimination agenda. So our doors are open. We're happy to have conversations with anyone that is interested. Professor Shankar, thank you very much for this invitation. And I hope that we'll be able to build more stronger partnerships that will enable us to reach the elimination targets. I'm not very hopeful that we'll reach it in 2030, but we can go a long way if we work harder, if we muster the political will, if we mobilize the resources that are needed and use the low price available tools that we have, not just the ones from the high income countries, but indeed the solutions that are being presented to us from countries like India. So once again, I thank you very much, and I apologize. As you can see, I'm all tealed up and I'm at a teal function with some young students. Thank you.
Thank you, ma'am. Thanks a lot for letting us know the extraordinary work you are doing there in Nigeria. And thank you for acknowledging the efforts in India. And we hope that this relationship which you are expecting between India and Nigeria, it gets established and we are able to fight together against this cervical cancer. So there's a question from Mr. Muhammad Kabir Kabara. He's a Nigerian and he has asked you, ma'am, how do you think HPV vaccine hesitancy can be reduced among Nigerian women, considering the fact that the bulk of Nigerian population lies in the northern country? Also, is there a rapid diagnostic technique for cervical cancer?
Okay, so to the first part of your question, very important, and he's obviously in Nigeria. There's a lot of vaccine hesitancy. And the reason I'm able to quote a figure like 12 million is because we're in a high population country. So even if just 10% of them get vaccinated, we will have high figures. what has happened is that a lot of misinformation was flying around, especially on social media, that was used against the vaccination. What we do is that we enlist the help of stakeholders like religious clerics. Like I said, I'm at a program where I just finished addressing a room full of young boys and girls, maybe about 200, and I asked them to put up their hands, those that had received the HPV vaccine. Maybe about 4 girls put up their hand, which, was totally not good enough considering a country that has had a first and second rollout. So the key is to continue working with the community gatekeepers, working with the media, both conventional and social media, and to dispel those rumors. We have to get the influencers on our side. A lot of the negative information came from high influencers. If Mohammed, who asked the question, I'm sure you know the Brekete show. The Brekete show did a lot of damage. A lot of people listened to it. It's a morning drive time show, and he just went on air and totally debunked everything that we had worked on the HPV. In terms of the testing, sorry, what was that question again? Is there a cheap test? Is there a cheap solution for the cervical cancer? There are 3 ways in which we test for cervical cancer early lesions. The visual inspection, which I'm sure you will hear about during this webinar. There's the VIA, the pap smear, and the HPV high performance test. The high performance test is the recommended one, but the facilities are not as widely available as we would like. But thanks to COVID, we now have a lot of PCR machines around the country, molecular laboratories that have the capacity, not necessarily that they are doing, but they have the capacity to do HPV testing. We just need to generate the demand and make sure that more people are aware, and then train the laboratory people so that they are more focused on HPV testing. It's not cheap. In the private sector, the HPV high performance test is about 30,000 naira. And unless we get a sustained and very strong partnership with government, we're not going to be able to do those 30 million people. So we're currently in conversation, having that conversation, how we can pull the machines that we have in the country that are able to do that test. And there are quite a few. We have one in Medicaid, but it's the affordability that is a problem. I hope that helps.
Absolutely correct. I cannot agree. I cannot agree much to you, ma'am. What you talked about, the misinformation against vaccine and the rumors, and you have correlated it with the religious things. Thanks a lot for your talk, ma'am, and we wish you all our wishes for your UICC presidency. Thanks a lot.
Thank you. Thank you for the support. Thank you very much. Thank you.
Now we are
for making it. Thank you so much.
Thank you.
Now let's move to the next session. I would like to introduce our chairperson, Dr. Mayank Singh. He is additional professor in Department of Medical Oncology Lab at All India Institute of Medical Sciences. Dr. Chandra Prakash Prasad. He is also additional professor in Medical Oncology at All India Institute of Medical Sciences, New Delhi. And Dr. Ashutosh Mishra, associate professor in Surgical Oncology at AIIMS, New Delhi. Over to you, sir.
So good evening to all, and I would like to thank Dr. Abhishek and the entire organizing team to invite us and to incorporate us in such a wonderful program that's a need of the hour. And we are grateful to our President-elect UICC for addressing the session. So without wasting time, actually, I would like to invite our moderator, Abhishek Shankar, for this next one.
I think panelist knows that they are the panelists for this. So thank you so much for making it happen, all the participants. And I think this is a very good response, and this really, motivates us to do more such program. So I will be moderating a panel about different cervical cancer elimination goal, what we can do. And I think it's a worrisome because when I wrote about eliminate cervical cancer, when I was coming to my office from my home, when I saw the Delhi pollution, probably doing a webinar on eliminate cervical cancer in AQI more than 450, really worry us a lot. And probably there's so much to be done apart from this. This is really scary. And I think I've just put everywhere blogs so that I don't want you to see the Delhi pollution, people who doesn't live in Delhi. So it might affect you at mental level. So this is, and I think probably this is another good opportunity for us to organize some kind of event or air pollution. I know this is not good to talk on air pollution on the day of Eliminate Cervical Cancer Day of Action, but I think it is hardly related. And I think probably I will do it because I have bought the subscription of Zoom for 1 month. So probably 1 month I will use the same. I don't have to pay extra. So to my panelists, I think I will just you know and name the panelists whom this question is directed to them so I can have more clarity. So, cervical cancer is often described as a preventable disease. But I think, in spite of this fact, so many women, close to 80,000 women, are dying every year because of this. Don't you think that there is much more to be done in terms of this preventable cancer? So, I will request Dipanvita, Sweta, Sarita to just give the oncologist perspective, their gyneconc, young gynec-oncology, emerging gyneconc. And I think I want to know that what are the plans to make this preventable cancer not a deadly disease in terms of cervical cancer? So please.
Shall I start? Dr.
Yes.
Shweta, Dr. Sarita? Yeah, thank you, Dr. Abhishek, for this question. So, as a gynec-onco surgeon, I would definitely say yes, there are lots of work is required on this field, mainly because of the population, the size of the population where we are in the country, and the armamentariums all are with us, we know, but we need more. And the main perspective as a gynec-onco, I would say that it is the lack of knowledge about the subject and lack of awareness about the disease itself or the HPV infection itself
Coming to this
contributes to
point,
the factor.
I will
Yeah.
just put in between. Do you think that being a gynec-oncologist, and there is a ops and gynecology, do you think that people who are trained in ops and gynae, they need further more awareness, more training in dealing with the cervical cancer, now cancerism more? So I will just request Sarita to or Sweta to answer this question.
Good evening, everyone. Actually, we know it is a preventable disease, but are we successful in preventing it yet? If you see the screening rate of India, according to NFHS data, it is still as low as 1%. Cervical cancer vaccine has been proposed to be included in NIP, but till the time it is operational, we cannot be very sure. And also, most of the cases present in advanced stages, and the radiation infrastructure in our country is below the and WHO recommended standard. And as Dr. Abhishek has told, the training, the gynae oncology as a field started only around 10 to 14 years back, and we have a long way to go in gathering a group of trained professionals who are able to do the treatment aspect and also the preventive aspect. So I think now we know what we have to do, but we are still way behind.
Sweta, what is your take on this?
Yeah, so what I feel, yes, it's a preventable disease. That it cannot be prevented has many issues. So there are barriers in understanding of the disease, both in the doctors as well as the patients. So for the doctors, I will say we all say that it is easy to screen, but how many of the even the obs gynae people will know how what test to use for screening and how to interpret a positive screening test. So we need a specialized training in this. That is one thing. Be it ops gynae, be it people from PSM department, we need a specialized training of how to screen. We should use objectivized screening to avoid confusions and this blurring of like there's always a subjectivity when we use a test like VIA. there's always a problem of quality control. So we should look for a test which is objective. We should be training the people how to interpret a positive test, and then we have to move beyond of how to manage a positive test. So this is an important barrier, and this is where we should focus. Apart from the thing that we should make the population also aware that what can be done to prevent what is the burden of the disease and what can be done to prevent the disease.
So it's very
It's not,
interesting. If I
it may not be just like we cannot say that gynec oncologists are the ones who will deal, because that is a very small population. If you are targeting
okay.
the whole country, we have to aim for people like even ops gynae people who have to be who have to have a streamlined training in this. Maybe also the preventive and social medicine, like DSM people, they can be also trained well in the screening per se, and how to interpret a positive screen and where to refer.
Okay, so point well taken. Training is required and it is not related to the ops and gynae. It should be all the people who are engaged in gynae cancer care. And I think related to the burden of disease, probably everybody should be well aware about what is the burden of disease in India, globally. Otherwise, when you're dealing with the problem and you have no idea what the problem is, it's so difficult. So it is very, very important to understand the marketing perspective of any disease. So we have Nilima Dwivedi ma'am. She is from MSD. So I just want to understand, how what is the company perspective, industry perspective of cervical cancer? This is a disease which gives you lots of opportunity. Maybe I find that this is a disease of the poor people. So don't you think that there's not much of marketing determinants in it? What is your perspective and industry perspective?
And thank you, Dr. Shankar, for this opportunity, first of all, to share industry perspective with this August gathering. So, as you mentioned, and also my earlier speakers have mentioned that HPV is preventable, right? And HPV related diseases and cancers. So basically, our focus is on prevention, and prevention of HPV related diseases, including cervical cancer, is something where we as MSD are really committed. Um, and if you look at the data, um, 1 out of 13 cancers are HPV related cancers, and every 5 minutes a patient dies in India because of HPV related cancer, right? Around 77,000 women lose their lives to cervical cancer. So while in one hand HPV cancer is preventable, but this is the data says something else. And the major reason which everybody is talking is basically the timely screening. Then of course there is a vaccination available for last so many years. The first vaccine, I remember, the vaccine Gardasil was launched sometimes in 2008. But the irony is that still the awareness level is so low,
Um,
right?
Probably personally think the cervical cancer care more of a demand size problem. You have enough of supply, but how to convince? If I see in my medical
Yeah,
fraternity, the
yeah.
uptake for screening and in terms of vaccination is very, very low. So
So
we are talking about
it's yeah, yeah. No, I totally agree. It's basically and that is why we have categorized as 3 A's, which is awareness, access, and action. So MST is really focused on all these three A's. The first is awareness. So we have driven and we are driving a lot of campaigns, social media campaign and otherwise, to create awareness to the target group, which are, of course, the girls and also their parents. We are also reaching out to women professionals. But here, of course, the girls of that age, 9 to 14 years and little above, maybe up to 20, and their parents. And we are trying to create awareness about the disease and how it can be really prevented. So that's one. Access, of course, we are working globally. MSD is working with Gavi and UNICEF to provide
ma'am,
equitable access
yeah.
to
I will
to
come to that point because
that's
I
right.
think, yeah.
Yeah.
So probably this is a good message to everyone. If you are just struggling for the funding, for the awareness and access, you should contact ma'am for sure. So she's very, very deliberately said that MSD is doing, and I'm so happy that they are now concentrating on the awareness part. So we are talking about cervical
And
cancer.
just wanted to add, Dr. Shankar, that
Yeah.
not only that, we are working as MSD with IAP, with Foxy, and here I really appeal with all my fellow panelists and the audience and the August audience that MSD is really open for such partnership.
That's
Please
great.
let us know what all we can do to really create awareness and increase access through action, the 3 A's, what I talked about,
Okay.
through this partnership.
Okay.
So
So
this is my
Divan,
appeal
yeah.
and message to all of you.
I think
Thank
it
you.
will be a very prompt appeal and everybody will take it. So I think the Dipanvita, so cervical cancer elimination we are talking, and I'm sure that many of us has no idea what is the elimination. When you call it elimination, please elaborate in brief. When you can call it, what is the definition of elimination in terms of cervical cancer?
So my job has been made easier by Dr. Cherian's talk. So elimination is like when does not become because cervical cancer is a public health problem. So there are multiple factors associated with it which causes or which has a direct or indirect effect on the incidence and the control of the cervical cancer itself. So it will, by definition, it is that it has been documented that the disease becomes rare when the incidence of the particular disease is less than four per 100,000 women.
That is
So
what I
this
wanted
is
to
a
know. Okay,
this is
so
for the cervical cancer.
cervical cancer elimination.
It has been WHO has advocated this, that by 2030, if we can achieve or if we want to eliminate the cervical cancer, the number should be less than 4 per 100,000 women.
Okay, so that's an important information coming to, because Dr. Cherian has clarified so many things related to 90, 70, 90. So I will ask Sweta, what are the three, four challenges that you see in terms of cervical cancer screening? Just in bullet points. These are the 1, 2, 3. These are, if you get an opportunity to work on that, these are the three areas you will be interested to improve the barriers related to cervical cancer screening.
I already mentioned before the three challenges are most important: awareness amongst doctors who are going to be
Okay.
the caregivers,
Mm.
awareness for the patients, and
Okay.
third is quality control. We
Okay.
cannot launch a screening test which is either a subjective test or a test which is not validated, and then it fails before the launch. Okay. So we start a screening test, it is not quality control. After 10 years, we say, okay, the test didn't work. Means I'm talking about some few HPV tests which are non-validated in the market. So whatever screening test we are wanting to use, it should be objective test, give result in terms of positive, negative, so that it is clear, and it is quality controlled, validated test. So
What do
these
you
are the
think
three
about?
most important.
Yes. What do you think about its sensitivity and specificity and chances of decreasing mortality? Because we do VIA, we do PAP test, but are you convinced that if nobody does screening for their pleasure, it should reflect in terms of mortality benefit? So do you think mortality plays an important role which we are not focusing right now? There should be a concern like in breast cancer, lung cancer. We say that okay, this reduces the chances of that particular cancer by this many percent. So that approach should also be applicable in cervical cancer before advising a test to the patient.
Maybe not, because apart from mortality, there are many issues in terms of overall morbidity that the patient has with treatment of cervical cancer. The patient develops it. So surgery itself has a morbidity. The radiation again increases the morbidity and in advanced stages. So there are many other things to focus before we focus on the mortality. If we start focusing on mortality, it will take a long time for us to say that, okay, this is effective. We can focus on less on targets which are easily measurable.
I understood your point. Devanvita, the same question in terms of vaccination. What are the three barriers you think that is challenging for all of us in terms of achieving the goals related to vaccination?
If we talk about three particular points, in my opinion, one is awareness, the first thing. The second is the cost of the vaccine at present. And the third point would be like the vaccine hesitancy. So which is actually integrated with the vaccine awareness about the subject and the HPV infection and associated spectrum diseases, associated diseases.
Don't
So in
worry,
my
cost.
opinion, this.
Don't worry, Nilima ma'am is here, so cost will be reduced from MSD side. So don't worry.
So
I think you have raised an important point.
so that's
So
why.
related to the treatment, I think Sarita, will you explain that? What are the challenges you feel as a gynecol? That these are the challenges you work at All India Institute of Medical Sciences, starting from your MBBS till the last MCH. So what are the challenges you face? Tell me the three one in bullet points.
Yes, sir. I would be dividing pre-cancer and cancer separately. For pre-cancer, there is a high loss to follow-up rates even after screening, because in most centers the referral system is not well defined and there is significant heterogeneity in even in between the facilities. If you look at infrastructure and staffing, there I have seen substantial barrier over there in providing treatment for precancerous lesions, along with trained secondary healthcare workers who are able to do a conization or a leaf surgery. Now, if you look at all these factors, then screen and treat is the best option for our country. But for that also, we have to do a lot of work. Now, coming to cancer, sitting in AIMS OPD, I saw a lot of patients coming after inadvertent simple hysterectomy. And that if I have read Indian papers, and in that the rates are as high as 20%. And there is one paper from AIMS, and in that uh, around 50% of patients had presented with residual disease at presentation. So this were mainly due to failure to perform any pap smear or clinical examination. The clinicians had incompletely evaluated the CIN and they underwent an inappropriate treatment. And apart from this, there is also a significant delay when patients are diagnosed with cancer and they are referred to the oncology center. And one paper has said that at least 30% people are referred to an oncology centers and they reach an oncology center more than 100 days after surgery. And as we all know, the outcomes of these cancer cases are better when they are managed by specialized and trained gyne-oncologists. And as I said earlier, the RT facilities are also inadequate as of now. And in places where there is teletherapy, but most of these places lack brachytherapy. So patients have to travel to far off places just to get their treatment completed. And from a patient perspective, I have seen a lot of patients just abandoning their treatment in between due to lack of money for travel and expenses. And even the caregiver who is accompanying the patient loses hope midway. So, and lastly, there is very poor access to palliative care also.
So I think cervical cancer is a disease of low socioeconomic strata. And I personally think poverty is the biggest crisis. And if you have to deal with a cancer, cervical cancer, which needs treatment for longer duration, for which you have access, don't have an access, and 90% of cancer centers are situated in the urban areas, but 70% people still live in the rural part. And we have a habit of going to the big centers and big cities for the cancer treatment. So we have a pediatrician, Dr. Roy, Dr. Shubham. So I would like to know what is your perspective and how much is the practice of HPV vaccination, both to the female and the male child in your practice. Can you elaborate a little bit? And what is the, the mindset of the parents when you talk about a vaccine Gardasil 9, which is a costly but covers 9 subtypes in comparison to Gardasil, which is a 4 quadrivalent vaccine, and how they just go between Gardasil 9 and how cost plays important for them, even people can afford it. Please explain it. This will be interesting to hear.
Yeah, thank you for this question, Dr. Abhishek. So while the vaccination part is largely on us pediatrician and the onus lies on us to convince the parents to go ahead with the vaccine. So right now, as we all know that HPV vaccination is not included in the universal immunization program. However, in the private sector, what we are following is the Indian Academy of Pediatric recommendations, And IAP recommends both the vaccine, that is the quadrivalent and the nonavalent vaccine, both are being recommended by the IAP. So here, when we are counseling the parents, what we do is we offer them the choice. We do counsel them about the benefits of the nonavalent over the quadrivalent vaccine. However, often price is something which is prohibitive. And majority of patients, despite counseling them that nonavalent is better, they opt for the quadrivalent vaccine. And what IAP recommends is for 9 to 14-year-old girls, both quadrivalent and nonavalent are recommended in 2 doses, 6 months apart. And for boys also, IAP recommends vaccination between 9 to 14-year-old boys. However, only the Gardasil 9 is licensed in India for use for boys in this age group. And we recommend 2 doses about 6 months apart. So this is the usual vaccination schedule that we follow. However, like you mentioned, the most important factor here in convincing the parents is the price. And sometimes we do get queries from parents that even the quadrivalent vaccine from some of the indigenously developed brands are much cheaper as compared to what we are usually offering. However, having said this, most parents do agree that taking the vaccine will be better, and they do end up taking this, but often the choice is the quadrivalent vaccine, unless the price is not prohibitive for them.
So have you, come across any parents went for the quadrivalent, the nonavalent vaccine, and they paid you the price and they went and searched for the online cervical cancer vaccination cost in India, and that will cost them on Google 2,000 rupees. Did they come back and fight with you? Did you come across any
I
such
have
history?
had
Because
one such experience previously where when we explained, the parents did choose the nonavalent Gardasil 9. However, after the second dose, the parents they Googled, then they came back to me saying that the cost is only 2,000, somewhere around 2,000. Why will we charge this amount? So, anyways, once we explained it to them, that was sorted. But we do come across such scenarios.
doctors should choose their patient wisely, and you should explain about the economical determinants of vaccine. So now we have, I would like to call Mary Ekins. She's a very dynamic CEO of IGCS. So I think so many advocacy program has been undertaken under the leadership by IGCS. We have recently completed the uterine cancer. So I just want everyone to understand that how to boost cervical cancer advocacy, and what is IGCS plan to assist low and middle income country to achieve elimination goals. Mary, welcome here.
Hi, thank you very much for having me today. It's a pleasure to be here. And what a great panel that you've assembled today. There are lots of ways in which IGCS is boosting cervical cancer, advocacy, especially in the low and middle income countries. We're an organization of over 9,000 members now, and truly balance the globe in terms of high, middle, and low income membership. We are soon to release in January, as part of Cervical Cancer Elimination Month, a statement on vaccination, ensuring that 90% of girls are fully vaccinated by the age of 15, and helping to highlight the countries where vaccination implementation programs have been successful, like Kazakhstan, Nigeria, Rwanda, and others. Of course, screening is a very important part of this as well. We, 18 months ago, implemented a robust pre-invasive cervical cancer education program for our membership. It's a self-paced, modulated online learning that is followed then by an in-person workshop, which we just conducted at our annual conference in Dublin. We've had over 500 of our members take advantage of our pre-invasive learning certificate program. And we're moving those stages forward as well. And in 2025, we will be in person at 5 locations globally. And then, of course, treatment. IGCS is an invasive surgical cancer organization geared towards the surgical mentorship and training programs. We have 25 programs in low to middle income countries in the world, training in surgical treatment. We have started our first radiation oncology program for mentoring and training, and soon will be pathology. So IGCS is committed to the multidisciplinary team when it comes to mentorship and training. And then finally, palliative care, a very important aspect. We believe in the well-rounded part of advocating for patients is the palliative care aspect of women's needs and making those needs available to women and to their practitioners. So I think in terms of like where to focus in terms of IGCS and advocacy, definitely at the community level, we believe in capacity building, of course, advocating for policy change. IGCS is happy to partner with any of our member countries on advocating for policy within the ministries of health and other levels of government. Of course, equity and access. And then we couldn't do anything without global collaboration. So we're happy to participate in many ways. I'm excited to come to India next month and participate in some of the gynecologic oncology activities that are happening there. Thank you.
Thank you. And I think welcome, Mary, in Delhi. And before Delhi, I think you're welcome through this webinar in Delhi. So I think I would like to, as we are talking about the cost of vaccine, which is most important issue for practicing gynecon, pediatrician. So ma'am, I would like to know that, how company perspective on funding advocacy campaign and what are the, efforts as a company you guys are taking to reduce the cost of vaccine price quadrivalent and this Gardasil 9 in India. So briefly, I just like to understand, and everybody would like to understand.
Sure. Yeah. So as I mentioned that MST is committed to equitable access, and we are working with Gavi and UNICEF. Even earlier, we have worked with the government of Sikkim, and we have started state immunization program over there for the girls between 9 to 14 years for many years, and also with the government of Punjab. In addition to that, we are working with various not-for-profit organizations and providing access to these vaccines at a cost-effective price, the best possible price, differentiated price, what I can say. In addition to that, Dr. Shankar, since we are talking about elimination of cervical cancer from India, in fact, last year during the interim budget Government of India has stated the ambition to run national immunization program to vaccinate girls between 9 to 14 years to eliminate cervical cancer. And this was one of the key steps towards elimination. Out of 90, 70, 90, I think this was one of the key as far as the prevention or 70 goes. And here we are really committed as MSD to support Government of India's endeavor. In fact, if you look at the recommendation, while we as MSD, of course, we have the regimen of vaccinations. But if you look at single dose for large scale program, which really makes it very, very cost effective if the NIP or any state immunization program is implemented. As per SAGE WHO recommendation, it is single dose, right? Also, NTAGI and IR recommends that. So I think when we talk about cost effectiveness, it really brings down the price, the operational cost, and everything drastically by 50%. That's one way. In addition to that, of course, we are very much committed, and MSD will make its effort towards immunization under NIP or any state government programs. So these are few of the initiatives which we are very, very keen to take, and we are taking with state government and partnering. As you might be aware that NIP and partnership, MSD has a global experience, and we have worked in implementing NIP in 177 countries till date. We are really looking forward for such opportunity in India to make it really cost effective, and also as recommended by SAGE WHO, under mass immunization program, only single dose is required.
Okay. So we have Raj Lakshmi ma'am. I think ma'am, I think you're from media and you yourself as a cancer survivor. So what things change? You command communication and you are the guys which can reach to larger population through your efforts. So what change you made, efforts you made in your day-to-day life to make people more aware, I just wanted to know that, your perspective.
Okay, Dr. Shankar, can you hear me?
Yeah, ma'am. We can hear you. Thank you for joining. Yeah.
First of all, I'd just like to clarify that I'm not a cervical or cervical cancer survivor,
The cervical
but I'm
cancer.
generally a breast cancer, breast cancer survivor. So yes, and I share all the concerns that several people have already spoken on, including you, about the importance of screening, about the importance of awareness, about the fact that a huge proportion of our population is extremely poor and does not have access to several health services. Forget screening and also access to cancer treatment. So and in fact, I just read, I mean, in the chat somebody suggested, I think it was Dr. Cheran Varghese, who suggested that women who come to the healthcare systems or who are either they come or they're part of the health systems, they should be given an opportunity to get themselves screened, because I mean, this case of, the government can't go to the people, and the people are sort of coming to government hospitals as well as private healthcare institutions. There has to be some system where this screening is offered to them free of cost. I mean, because I think given the kind of precarious economic lives that people do lead, it's extremely difficult for them to sort of take time off from their occupations. Also, many of them are, as in fact, in the unorganized sector, and they're daily wage workers. So it's not possible for them to really sort of get themselves screened, unlike middle class or maybe upper middle class women like me. But so this concern has to come, I think, from the right quarters, and who else but the state? I think the state has got the resources, the state has got the manpower, the state has got the reach, and I think it is a state in the sense, I mean, that the government should take this head on and should go to the people with all these facilities. We can't say that people, the onus of getting aware is on the people. I mean, it's not fair, really. I mean, I think the two things, health as well as education, are things that every government should access to its people free of cost. And it's not only just free of cost. I mean, I think quality healthcare. I mean, essentially, we're talking about quality healthcare, and all these concerns have been expressed by several of you. I mean, the costs of the vaccine, for instance, that itself is a disincentive for so many people to so many parents to come and seek treatment. I mean, if at all that stage arrives. So I think screening as such is something that should be made available. Essentially, I feel, because as a cancer survivor myself, I have seen in my sort of multiple trips to hospitals, I have seen the kind of backgrounds that people come. They sell off property, they sell off the land. If they do not have any assets, they take loans, they enter into huge amounts of debt, and then they come when at the final stages of the disease, which is sort of irreversible. So if we are aiming at prevention, I think awareness as well as prevention is something where I think a lot of money and a lot of resources should be put in, rather than look at the treatment part of it. The Of course, the treatment part is, I mean, equally important, but I think if we were to focus our attention on these two aspects, I think we would have saved ourselves a lot of heartburn, I mean, in the long run, as a nation.
So I think this is very important, screening and vaccination. Screening, I personally used to think that we should do it, but later on, many of the state governments ask us to do screening to assist them, but they don't have a screening. You may have cancer, but there is no pathway, what to follow, what is the follow up. And personally, think that there is a, we are in the country where we are having the bullet trains, we have Boeings, but at the same time, we have the bullet quads. So we have to make a balance between each and every component of cancer care so that it is integrated. But yes, the screening is an important thing because this gives a critical opportunity to save your life from that particular cancer by detecting it early. So we have Nagmaji. So I would like to ask, how to get media engaged to boost public awareness directed towards public, because I have been in your program, you are very, very active, to deal with all the public health issues, which is very imperative to the general population.
Okay. So thank you so much, Dr. Abhishek. I think as traditional media, which is television and the print media, the reach still is huge, even though we all know that people are shifting from the traditional media to the social media platforms as their main source for news. But traditional media remains the primary source for news consumption in, smaller towns and villages, especially platforms like Doordarshan and news channels. So what I feel, if we collaborate with news channels, the traditional media like newspapers, what is required first in terms of cervical cancer is awareness about cervical cancer. Because believe it or not, even though all of us are, educated and live in the bigger cities, but still the awareness related to cervical cancer is very a few years back, it was very, very limited. People would not really know what cervical cancer is. I know few people asking me, I did a show on cervical cancer, and some people were actually totally unaware. I mean, within office premises and elsewhere, that what is it? Is it cervical? Is it cervical? Or what is it? So what I'm saying is, through popular programs and programs like when I did a show on cervical cancer, at least we get to know and tell a vast audience of what exactly is cervical cancer. And that is what is first needed. So people become aware. Then people should know what is it. Then people should know what are the options that they have for their treatment or even for vaccination. I have been hearing this conversation. Everybody with their own expertise talked about various aspects of it, the cost of treatment, as well as the awareness of vaccination. As far as vaccination is concerned, I think we need to spread awareness, but there should be transparency. A lot of people also are very concerned. I have met people who are concerned regarding the safety aspects, regarding the, the ill effects of vaccines. So, to come very clean on what is it and how effective are vaccines and do they really prevent? And, the treatment part of it, if women are getting cervical cancer, what is the treatment that is available? Like you had mentioned earlier, Dr. Abhishek Shankar, that, a lot of patients are in the rural areas and all the facilities are in the urban areas, the treatment centers. So to bridge that gap also, we need to bring in awareness. Traditional media remains a very strong component which can help in disseminating the information regarding the disease, as well as how to tackle the disease. So that, shows need to talk about it. And I think that there is very little talk still on this aspect. I just remember I've just done a show on diabetes today, of how can we tackle diabetes, because 2 days back we had the World Diabetes Day. We still need so much awareness on those. So there are shows like these which can be done, and hence awareness can reach people in far off places.
So I think I will request Chiri and Verghese sir to comment on the safety and efficacy, because you have been the regional director for this share reason, and you work extensively in WHO at Geneva.
Thank you. Thank you, Abhishek. I was just following the conversation. I think it's in the right direction. But as of last year, 140 countries have introduced national level HPV vaccination. That includes almost all the high-income countries of the world, and large countries like Nigeria, Bangladesh have also introduced. So I think at least safety-wise, there is absolutely no worries. Cost-wise, yes, I think cost is still an issue. The Serum Institute vaccine, which is a quadrivalent vaccine, I think once WHO pre-qualification happens, this is going to be much cheaper and easier. Maybe it will be available through Gavi. Gavi pricing is much less than the open market pricing. So HPV vaccination, the first one to push, which is the most feasible as a one-dose vaccine. School attendance is very high, so school-based programs can be done. And given that 140 countries have introduced into their national program, safety also is totally taken care of. So that is the HPV vaccine story. But more vaccine farm manufacturers should start in India. I think India has the capacity of the vaccine manufacturing in the world, as we have seen during COVID. So I think there should be more work from the private sector on that. Thank you.
Okay, so I'd like to, understand from Mary, because you have been CEO, you have been reaching out to company for the advocacy campaign, and probably people, company sees the sites when you have talking about immunotherapy, their drugs, the other products. So how difficult it is to get a campaign which is on advocacy funded from the industry, and what is your experience? Or you get the fund very easily from the company, I guess.
Yes, it definitely can be challenging, right? So we unrelated but similar to cervical is, IGC has declared June now to be Uterine Cancer Awareness Month. So we've taken these steps that we have used successfully with our cervical cancer campaign, World Ovarian Day, and applied a lot of those principles to our new campaign, which is cervical or uterine cancer elimination. I think there are a lot of similarities, and I think definitely understanding the audience, understanding where there's mutual overlap and interest in a campaign goals, so that industry, other government funded grants, and non-NGO funders find that you are aligned with their goals and that your goals. So whether that is a screening program, maybe that's a vaccination program, but it's important to learn their priorities and find if and where that overlap in priority happens. I think it's really important to be clear on the objectives of the campaign. Seeking funding requires clear objectives, a detailed plan, and if possible, using an evidence-based approach to show the effectiveness then of the campaign. And of course, establishing your budget and transparency in budgeting. There are lots of expenses built in. Some companies will allow for an overhead, to kind of fund a project manager, fund our communications team to be able to do the effective work that they need to do. Also understand what other organizations are doing. There's a lot of overlap and repetitiveness. So if you can find the gap or your own niche within your communications campaign, you'll certainly have, lots more success and ways in which you can obtain funding. I don't know. I think it's a challenge for all of us. I think there's a lot of plates that are spinning, if you will. But if we're all kind of spinning and working in the same direction, I think we'll have a lot more success. And it would be great, especially in the cervical cancer elimination, if there was like a national registry or somewhere where we could put all the work that we're doing, right? And you could go in there and search and say, wow, they're doing this in Mumbai. I think this would be great for us, right? Programs that are scalable across other parts of the world, I think, are incredibly important and of interest to industry as well.
So one important thing, people are highly confused about the choice of vaccine and dose of vaccine. There is which one is the best one. There are indigenous company, the innovator one, and the dose, they should go for the single dose. And probably, Sarita, I would like to understand that, in the community-based setting, because government has decided to vaccine at community level, or when somebody is coming and visiting your tertiary cancer center, is this two approaches should be different in terms of vaccination, or you use the same formula for both?
I think we should start the vaccine according to the place where we are working. Till the time the vaccine is introduced in the national immunization program, we should start propagating for our Indian vaccine, because the Indian study which compared the Gardasil with the Servavac, it showed equal efficacy. And that will highly decrease the cost. If I tell my patient to purchase Gardasil 9, it costs around 9,000 now. But if you tell them that there is a Indian vaccine which is much cheaper.
So, same way, I would like to say that if you talk about immunotherapy, you talk about the other genomic sequencing, don't you think that the person who can afford, the same place, they can be choose
sir.
for the robotic surgery? So I'm asking about the standard choices,
Yes,
standard
I
choices.
yes,
So
sir.
what else will be the standard choices? Because if I can use iPhone 14 in the era of iPhone 16. But if given a choice, I would use iPhone 16. So I just want to know about this.
Definitely, sir. Sir, what I do, I give the
Yeah.
patient a choice of all three vaccines, and I tell them whatever study has been done and whatever data is available, and based on that, they can pick the vaccine based on their financial situation.
Now, practical information. How many times doctor discuss the studies to patient?
Well, I have been doing it, and I
Okay,
think
that's
now
good.
the patients are more aware and they have started asking
Okay.
questions. Uh,
Yeah, that's fair one. And I think given an opportunity, but if patient can say, okay, money is not a concern. So, and which vaccine you will choose to widen the coverage? The nonavalent or quadrivalent? Money is not a concern. Which one?
Definitely monovalent.
Okay. So, Sveta, I would like to know that same with the screening. Which test people should go at, what will be the age, when to stop it. There is lots of confusion. So please highlight, what should be the age when they should start cervical cancer screening, when to stop it, what is the ideal test they should go for. Practical, I'm not asking because this is already in place with the, framework for the screening of common cancers in India.
So first of all, it fortunately for cervical cancer screening as of now, the confusion does not exist regarding which type of screening test is best. We know HPV test is the best. The problem is there is a problem of affordability and government intention to launch it on national basis so that the cost can come down. So, like we are talking about Gardasil 4 and Gardasil 9 and affordability, and that the government has the 4 and the 9 is the costly one. I mean, those sort of confusions doesn't exist in screening. It is HPV test, which is objective test. It is the best test in terms of sensitivity. The cost can come down if the government wants. There are ways to do it. It can be brought as a national program, and they can collaborate with like the different societies to work on that. But in case we for the past 10 years, the compromise that we have been doing by saying that we are a developing country and therefore our funds are less and we should be moving for a test which is feasible and something like VIA. The problem is we start with that and then we consider that as a standard. Until now, the standard has not changed.
Okay.
So I'm quite concerned with that because still there are people I have worked in best. Fortunately, I've got the opportunity to work in best of the institutions where people are still going for a test like VIA and Pap smear.
I think this is a very important.
It is very
Yeah.
difficult. It is very difficult to convince them that a test which may appear more costly is going to be a lot helpful and maybe a lot cheaper if applied on a mass basis. And the kind of objective test it gives will have a lot of quality control to further decrease the cost. Quality control is has a lot to play when we are talking about overall cost
Okay, so that is the
effectiveness.
important one.
So
It's a HPV DNA is a cost effective. So you may decrease the cost by some, but it is not effective. So HPV DNA is a standard one. If get an opportunity, just use this test. Ask your doctor that these are the tests we require to do it. So that's an important message.
and now when I say about HPV test, again, it has a lot of challenges because I see number of labs coming up saying that they are doing HPV test. Everyone is doing HPV test because it is they are saying that it is RT-PCR based and without any quality check without any validation they started doing. So I have again the second apprehension that the screening program may fail before it launches if we don't have that quality control also. So a lot has to go in the quality control of what has to be used for screening and what is the validation of it. That is the first thing. Now about the age of screening, if we talk about our goal of elimination, what has been said is 70% of women has to be screened by high performance test, and they have said 35 and 45 years age group twice in a lifetime. However, as a national program, I think the ideal age at which screening can be started is 25 years. And
It's 30 to 65. 30 to 65 is the age with the VI
yes,
every 5
30.
years.
Yes, 30 is what has Fox said, but I think I have seen cases of cervical cancer, HPV based, between 25 and 30 more
For
than
H,
once.
okay, well,
So I
HPV
think,
you can do at 25. Now, the American Cancer Society says they have reduced the age to 25 now.
yes. So that is
Yes.
what I'm saying. 25 should be the ideal age. But if we talk about implementing as a national program and that two tests in a lifetime, then 35 and 45 is okay.
Okay. So
And
that's important.
every 5 years, it should be done.
So I have many important, most of people know how we tried advocacy in India. No one influencer faked her death to promote cervical cancer awareness. This was so bad, and we have just addressed this issue in Lancet through our commentary. And I just want to know because now influencer is has become a very scary word after that incident, and for us. And it's really, that campaign, and everybody started talking about after her fake death, and that campaign got life, and after that campaign got dead once she became alive. So that I don't understand. I just want to know about the two media specialists here, Nagmaji and the ma'am, Rajlakshmi ma'am. What do you think about such incidences? And I know you people are largely followed on social media. Can you help doctor like us if we come up with the evidence-based information? These are the important information. We can collaborate with the media personality of large following, because people are now influenced by media persons so much. So you are a star and influencer for us. So will it work? Do you think that, because you many times you want to tweet, but you think, okay, whether it's right or wrong information, am I the right person to do this? If anything goes wrong, people will come that, why are you doing this? So do you think this kind of, collaboration between doctors and media person will help us to reach more number of people? Nagmaji and Rajlakshmi ji.
Okay. Okay, if I may take the opportunity to answer this. When you mentioned that case about the, an actress, an influencer faking her own death and then, coming out, that was, I think, very objectionable and a typical case of irresponsible action. You have influencers, you are an influencer, you have following, that needs to be responsibility along with it. And as far as social media is concerned, YouTube is concerned, or it could be Instagram too, this is still a very, very big concern. Only today, the Minister Ashwini Vaishnav, speaking about the conventional media and the social media, mentioned this. The one big problem, I mean, even though the reach of social media is huge, one big problem remains the responsibility and the authenticity. So we need to be very careful. If doctor fraternity thinks about collaborating with social media influencers, the need to see, I think, along the numbers are important for sure, but I think it is very important to see who we are collaborating with, the credibility of the person concerned, the background of the person concerned, because now we see that very often a lot of people are doing many things just to get the views and to gain followers. So social media, while remains a very important tool to spread awareness, I will again say that traditional media remains more credible for that reach out, because there are always checks and balances. Social media is also a very important tool, but there needs to be that a caution of who are we collaborating with and who are the influencers. The reach is huge, but there is always that kind of danger that needs to be kept in mind.
Okay, that's very rightly said. Rajlakshmi ma'am, your point of view on this.
Of course, I couldn't agree more with what Nagma said. I mean, essentially, it has to come from a certain responsible agency because it's about health. It's about it's not about selling kurkure or about chips, right? I mean, it has to come from a responsible agency, and who else, but the medical community, and who else uh, but the system that is the government. I mean, here when I say system, I mean government. I do not even, I would not even, in fact, give so much importance to the private sector. I think despite their good intent about outreach, and various things, obviously it's a huge market out there. Okay, it's a huge market. Vaccination is a huge business. Tomorrow, if you say that all the women in this age cohort have to be vaccinated, it is. I mean, it is big money. The government, somebody subsidizes. Huh? Either it's a patient or it's a government that subsidizes. But I'm saying that the principal onus for healthcare in any country in any given situation lies on the state. It can't outsource these responsibilities. Whether it's screening, whether it's treatment, whether it's in fact even messaging. I mean, how much more can I explain on the subject? Just perhaps as a generalist. But here are the experts sitting, and here when I see all the things being said, there are so many important things that one needs to know, and which can't be encapsulated through a social media influencer or through a few words, through tweets, or even through advertisements or flashy, flashy in fact, messaging, right? I mean, if I'm telling people through various ads and programs and go and get yourself screened, now they'll say, where do I get ourselves screened? Where do I have the time? Where do I have the wherewithal? Mera rozana marjuri chala jayega. My daily majority will go. I mean, where do we get this?
Yes.
So here you have to go. For instance, the mountain has to go to Muhammad. It's not that Muhammad reaches a mountain. It's an old muhavra. But I'm saying that this is what needs to be done. I mean, I think the onus lies somewhere else. Social media has got its drawbacks. I mean, they can convey something absolutely twisted and wrong, and tomorrow
Yes.
the effects will be felt by somebody else. So I think responsible outreach, responsible messaging has to come from none other than the government alone, I think, and it should not be outsourced. Essentially,
Yes. Yeah, I think you're right because this is a spreading the right messaging is a big responsibility. And many of the times we don't know the side effects of this. Many people have already suffered from that. When you write something, how it is, interpreted is completely different. So I would like to, talk to Ajay Narayanji. He is from the Rotary, and Rotary has done so much for All India Institute of Medical Sciences. Our cancer center is known as Institute Rotary Cancer Hospital. So they're working for many years with us to support cancer. So I think they have vaccinated 1,000 of girls here at All India Institute of Medical Sciences. So Ajay ji, your experience of this and what are the challenges you face and how do you overcome all these challenges to deliver?
First of all, thank you, Abhishek, for bringing Rotary into this program. I think we are very well connected with the cervical cancer and the problems people are facing, because I think it was somewhere in the late 70s that we set up the Institute Rotary Cancer Hospital. And now for the last 50 years, we've been working tirelessly along with the faculty of IRCH. As far as my understanding is, I think I'm very, very straight on this, that considering the cultural, socio-economic, and geographical factors in a country like ours, NGOs have to play and do play a very, very major role. The example for this is the polio campaign that was done by Rotary the world over. And I know the government and the medical bodies are doing their might to bring down the incidence of cancer or help people. But the thing is that unless NGOs come forward, NGOs like ours come forward and play an active role, but then we have to be supported by the medical fraternity. I'm very happy to state that we have got excellent support from all the doctors at IRCH and NCI in the last so many years, but I really don't know how others are getting this support. Just to give you a short this thing, we started about on the cervical cancer vaccination, as Dr. Abhishek, you know very well, about 8 years ago. I would say discount 2 years for the COVID, etc., etc. But 5 to 6 years, we've been very active at it. And I'm very proud to say, whether proud or whether we should have done more. On an average, we have given about 7 to 8,000 vaccine shots in a year. That means in the last, if we say last 5 to 6 years, the Cancer Foundation would have given about 40,000 vaccination shots to, and these are the people who are basically coming from the economically weaker sections of society. We have got our advantages that we have schools connected with Rotary, and most of these are the girls because the continuity for the first shot or the second shot is there, is been the we can get it done very, very swiftly and without any break. But we are now looking at concentrating just purely on the economically weaker sections of society. And I think we've got a very good support from IRCH, where I think in the last 6 months we have had about more than 100 or every month we have been vaccinating girls from the poorer section of society. As far as I think a question which has been coming up here is again an appeal to Mrs. Neelama Dwivedi of MSD, I would presume. We have excellent support from MSD, but then as far as the pricing also is concerned, I've been in touch with a lot of the higher people in MSD. The question time and again comes, 1 or 2 shots, even in the age group of 9 and 14. It is the work of Rotary can increase immensely if we get some sort of a clearance that 1 shot of Gardasil or whatever else, whether we would like to name it or not, but is good enough, or Serverback is good. I'm talking as purely as people working on the ground and facing these problems. Rotarians ask us, we are not sure, but we go back and tell them that WHO or the medical fraternity tells us 1 shot. These are the questions, I think, if they are answered, the NGOs like ours can do a tremendous work in this area. And I think it is the need of the hour. If like the government has opened, if we can come forward and join hands with the government, or government extends its hands to us, this problem about cervical cancer can be solved to a very, very large extent. I'm just talking about one district, Delhi and the NCR, where we've done so much work in the lab. We have 28 districts in India. And look at the work. If we get some sort of a support, a program is drawn up. I don't know which will be the authority who can approach us and tell us we would like to sit down and draw up an entire program for the year or for the coming years with an NGO like Rotary. I think you'll be amazed at the response. I get a lot of queries from people, Rotarians all over India, asking us about our program. I'm sure if we get that support and we can support these people, these numbers that Rotary can do will run into hundreds and hundreds of thousands. Rotary, because it's working in the economically weaker sections of society, slums, etc., etc., etc. I think we can do wonders, and I think initiatives like this that Dr. Abhishek Shankar has taken, I think are put up all across. To the Rotarians and the other NGOs would bring a tremendous help to the suffering humanity. Films of this, if we have, this is like recorded, we could send it to the districts all over India. Ask them to show them.
So I think it is recorded, sir. I will share it after this. So related to the dosing, 1 dose or 2 dose, I will request Sarita to clarify this. Up to which dose, if you are talking about, she can clarify. She is the best person to clarify this.
Sir, actually, Even WHO has given a message that either one or two dose, which creates the confusion among the masses and even the practitioners. So it
So
should be one or two.
I personally think that WHO is a guidance. Okay. So if we go by the India IARC study with the follow up, Dr. Partha and all, two doses can be extended to up to 18. In community basis, if there's a national level policy, one dose should be made standard to reach the, goals of number of people getting vaccinated, which is 70%. But for non-valent, Torreson, the studies are required. There is a no long-term follow-up. So I personally feel, irrespective of age, ideal will be 3 doses. If somebody wants to be one dose is essential. You should not leave. Everybody should get one dose. But if their pocket allows three related to Gardasil 9, for the Gardasil, probably now I can say one dose is okay. One dose is because now we have a long-term follow-up.
No, but
So
Abhishek, we are using Gardasil 4 at the moment.
so, sir,
That
for
is
the public thing and your community-based thing, one dose is okay. I think I will congratulate your work and the way you guys are working. Many of the institution of national importance could not do it, could not achieve it. Many of the states could not achieve it, and they're using the whole state machinery. So big salute to Rotary, because I can understand if you can make the cancer center of Ames, you can achieve anything. So so now the next is, I think we have a teacher from modern school, Ritika. I see
thank
work
you
with
so
us.
much. Thank you
So
so much.
yeah, so I would like to know, what kind of discussion parents come and do it related to the vaccination of the child, and how many times, try to address this issue in your, this school setting, Ritika.
First of all, sir, I would like to appreciate the information that has been shared here by all the panelists. They have spoken till now. It was very informative. And as an educator, so I believe it's my duty to spread awareness about each and every issue that helps our society becomes a better place to live in. And honestly, not so many parents have approached us and teachers and like the school for about this. Maybe so basically, I come from modern school, so anyways the parents are very aware, so we don't have to put in that much effort with them. But yes, there are schools can initiate some campaigns in to spread awareness. And recently I was reading about this national technical advisory group on immunization that suggests that these vaccines can be brought into school, and in the campus setting it could be administered to the students. So that could be a really good step to ensure that all the girls and the boys for that matter are vaccinated. And teachers for that matter have a very instrumental role with the parents. They trust teachers, like there is a very trusted relationship. So for instance, if something is coming from us, they're going to look into it more deeply, and okay, this is what the teacher is saying and maybe it's of some importance. And if it comes to school also through circulars or like notes or something like this on ERPs, so they will be more interested, and they would be like, okay, this is something that is important and maybe we should look into it. So teachers play a very they have a relationship with the parents, and if it could be like the teachers are made aware of this, it could be helpful. Yeah.
So we should try to make more, teacher ambassador for the cervical cancer elimination. I think it's a very right point. Even my son listened more to teachers than the parents. So I think that's a beautiful relationship. So I would like to introduce Eva. She has been vaccinated. Eva, can you open the camera? Man, can you help Eva to Eva? Hi. So many congratulations for getting vaccinated. So share your experience with all of us and tell us how many people, other friends you have motivated to go for vaccination.
I've motivated a few of my friends to go for vaccination. Um, I can't really say their names out loud, but I've motivated a bunch of my friends who are not actually aware of cervical cancer or HPV. And I've also motivated some of my friends, like some kids I don't know. But still, there are a lot of people who don't don't know about HPV or its vaccination. So I feel like awareness is really important for it.
Are you a kid who is so, not very fond of vaccination and you're scared of vaccination? Did you cry after that?
No, I don't really
You
cry
don't get
after
scared.
vaccinations. I
Okay,
don't get
that's good. And please, I think you are our student ambassador. So, and thank you for, making people aware. Yes, sir.
Dr. Shankar, I just wanted to mention, first of all, congratulations to Eva. And it's really great to see now our young champions really taking and driving for such public health cause. Again, you talked about pain. So now these vaccines are coming in pre-filled syringe, right? And it just takes a pinch, right? A very, very small prick. So I don't see a pain or this thing is going to be an issue. And also, like MSD has it, like supplies in pre-filled syringes, which further makes it very, very, very convenient to the vaccinators. Thank you.
So I think we are going. Yeah, sir. Ajay
Sankar,
Narayan.
because
Yeah.
modern school has been a very, very active partner of Interact with Rotary. Abhishek, my experience of all these thousands of children that we would have vaccinated is that till today, touchwood, we have had no adverse reaction no children has complained except pain for 5 minutes or red swelling. Nothing. We have had no complaints
Yes.
at all.
So
And yeah, but it's teachers will say, it is people like them who will have to come forward and be the brand ambassadors. Be brand ambassadors.
Sure.
yes.
In the
So
schools.
you
So
got
it would
one, Ritika. We have got Ritika. So Ritika will start the chain and she will add many one. We have Eva with us. So, I would like to ask point of care device. We have Mayank who works in cervical cancer. Point of device is one of the area. So do you think briefly in 1 minute, can you tell us that is its point of care era will help us to detect cervical cancer and most effective and in a cost effective way, Mayank?
Yeah, I think, yeah, am I audible clearly?
Yeah,
Yeah,
sure.
I think should be. Sure, yeah. Yeah, I think the point of care era is obviously it has arrived in almost like different kind of cancers as of today. And obviously, I mean, Dr. Abhishek knows that we have been working on point of care devices with our US collaborators for that to detect the methylation status in the patients. And I think that is the way forward. I think we can I think we can not for a long time we can just stick to like I will HPV. I think what we need to like get away from HPV and see like what other things are happening in cervical cancer. And I think obviously HPV is very important. I agree with that. And but like the new technologies, liquid biopsies, like one way you just collect the serum and you can just monitor the patient progress as we did recently in one of our projects to see the chemoradiotherapy response in the patients. And obviously, like it was an easy way. And those things, those kind of approaches can be taken to point of care devices. And the good thing about point of care devices, and I think especially in countries like India, is that they can have very far-reaching consequences on the way we diagnose and obviously then we treat their cancers. So that is one way ahead, I believe. And obviously, like I think that is a very far-fetched dream. But therapeutically, I think the emergence of immunotherapies in cervical cancer is still lacking, and I think that is also one way forward.
Okay.
Yeah.
So I would like to ask CP because most of the vaccine are produced from the industry side. So do you think that academia industry participation, more involvement and engagement from academia is one of the way to reduce the cost? And ma'am, Nilima ma'am after that. So CP.
Yes, good evening, everyone. So we have seen that industry and academia partnership have been instrumental in developing cost-effective vaccines. So if you look at the work of basic researchers who actually work in the lab, actually they work behind HPV 16 and HPV 18 strains, and they were the first ones to show that yes, HPV DNA, how it interacts with tumor suppressors like P53 and RB. So if you look at the work in the Queensland University in Australia, they developed virus-like particles VLP technology, which forms the basis of HPV vaccine if you either look at the Gardasil or GSK Cervarix. Now, if you look the Indian perspective, we do have a Serum Research Institute that collaborated with our ICMR, and they have come up with a quadrivalent vaccine for against HPV. And of course, we talk about the dosing and everything. So it is much cheaper compared to the other multinational vaccines presently. So what industry can do is that it can help the academics to commercialize the technology, scaling the production, ensuring regulatory approvals, and of course, they can help us with the distribution. And we have all seen the success of Rotavac. We know about this vaccine against rotavirus that was developed back in 1980s. Basically, they found a weakened virus strain of 116E. And then with the help of Bharat Biotech, they developed this vaccine. And this academic industry collaboration actually led to like $1 dose vaccine. So such vaccines, effort should be made, in India to develop such academic vaccines for HPV also. So this is what
yeah. Thank you, CP, for this clarification. Nilima, ma'am, you wanted to say something because we need to.
Yes. So, in fact, Dr. Mayank was talking about the importance of immuno-oncology or immunotherapy for HPV or cervical cancer treatment. Just wanted to call out that yes, there has been a few immunotherapy treatment already approved now. Indications have been approved, and a few of the immunotherapy treatments are being prescribed for cervical cancer treatment. So that's point number one, and very much available in the country. Second, on academia industry partnership, yes, that's a great approach, and MSD has always been open for such partnership. Also, in the past, MSD has worked with ICMR in HPV space, and we have been open for such partnership. And I totally agree that such thing would certainly, in fact, increase the reach of the vaccine. But partnership is not only one, of course, in developing or making it cost effective, but cost, I don't see cost as an issue. I see mainly the awareness is one of the big issue. People are not aware. In fact, Nagma was talking about that even today, cervical cancer sometimes being seen something happening in the neck, right? People do in fact get confused. So I think the awareness level is that low. So first of all, we need to really work on awareness part. Second, of course, vaccine hesitancy is a global issue, and it also prevails in India. So we, as I think the multi-stakeholder present in this call, we need to work together first on hesitancy part, and also the awareness part. Then only we can increase access. As far as cost is concerned, I think we can all work together. As I mentioned, that we firmly believe in equitable access, and we can certainly work it out. And price is never going to be a barrier in access.
Okay, so we have Asutosh Mishra. He works with UICC very closely and a very, very active surgical oncologist in the global domain. So I wanted to, his opinion, how to boost advocacy in terms of cervical cancer in India. Your point of view. You are on mute, Asutosh. You have to unmute yourself first.
Yeah.
Yes.
Hi, hello everyone. So first thing for to propagate any idea or any change in the system, first you need to make the system aware of this. So it should be done on the both side, on the recipient side, also on the side of propagators. So particularly for cervical cancer, in last 2 decades in India, particularly, we have seen a lot of changes in terms of vaccination, active involvement. Secondly, in terms of the level of hygiene. So trends are in decreasing way. So of course, these are all motivating factors. And in this scenario, when there is the active involvement of WHOs, NGOs at the global platforms, Indian political system, they are aware. Serum India, particularly, I have discussed the same issues of cervical vaccination with the director Hit Sharma. He was very closely monitoring all this system and working on the price reduction, particularly for the Indian domain. So currently, if we see, we are on the right track or right path. It's the time to take the advantages. Most of the funding agencies are ready to fund. It's the time for the NGOs, government systems to propagate all these things. I have listened all the from the aspects of NGOs, Rotary, school, media partners, clinicians, basic scientist. So all the mindset has already made up. They have made up the mindset that we have to decrease the incidence of cervical cancer, particularly, and it's achievable as I am seeing this. And yes, so it's a time to hit the nail. And I think that's it. And all I have listened, we have covered most of the points. So nothing much to add.
So I think it's a great session for this and too much of discussion. And we discussed every possible area, which is in terms of cervical cancer advocacy, cervical cancer care. And I think we have got a good number of. So I will just request the Bhanu, if we have any question directed to any panelist, we can take 2 or 3. That's it. After that, I need to close the session.
Thank you, sir. That was an excellent panel discussion. Most of the questions stand answered among the discussion. There are 1 or 2 questions that we can take. So the first question would be, if
it is answered by some of our,
yes,
if
sir.
it is already answered, there's no need to get the answer from one of the panelists. So already answered.
Yes, there's just one question that's not been answered. If cervical cancer is influenced by modifiable or non-modifiable risk factors, I think Dr. Chevian would like to take that.
Okay, so
I have already answered that actually. I've already answered that in the main chat. Since HPV is the single most important risk factor which is modifiable, I think we should say that it is modifiable, and that is why we are looking at elimination as a possibility. Thank you.
So I would like to one point of action from each one, given an opportunity, which one area you would like to invest. I would like to start with Dipanvita. One point of action from your side.
Yeah, thank you, Abhishek. Such a wonderful panel. Your panel itself reflects the importance of teamwork.
Okay.
So all the sector from all the community should come across, and enough of data we have, enough of armamentarium we have. We know everything about the disease, the vaccine, the cancer, pre-cancer. Now it's time to act upon, and it's time to come together and to act. And the ball should roll in one direction. It should move forward. And it should not be like.
Yeah, so basically, what I would like to call upon is that every parent and young adult should ask themselves a question, that why expose our children and ourselves to the infection or disease which is really preventable. So I think this is the question which we should drive back home, that if something is preventable, then why we are really taking risk. And I also request, and through this forum, I would like to really call upon all the parents and women to consult and have an open conversation with their pediatricians as well as with their gynecologist to understand more about HPV, because awareness is the key, and this is what we all discussed, right? And the most important thing later on is to make an informed choice post consulting their doctors. So I think these are the 3 messages which I would really want all of us to drive back home.
That's an advantage, ma'am. I asked for 1, you get 3. So Sweta, your one point of advice to the participants.
Streamline screening, because vaccination, if it comes in immunization program, it will be taken care of. Government will take enough measures to make the people aware and to give the vaccine. Streamline screening, that's very important.
That's good. Asutosh, your point of advice.
More and more awareness and decrease the price of vaccine in India. two
Ma'am
things.
has already taken the charge of it.
Yeah,
You
yeah.
will not believe that tomorrow you go to the shop and it is already reduced to half.
With
Ajay
the
Narayan,
pre-fill
sir.
syringe,
We
I
can
think
certainly
with the
make it
pre-fill syringe, the
together.
pain aspect has now the cost aspect has to be.
We will do awareness, ma'am. You work on the cause. Be assured you will. Point of advice. Sir, unmute yourself first. I think. Sir, unmute yourself, Ajay Narayan, sir.
My contacts who are there, they have also 2 days ago told me that go with one, but then people are not prepared.
Come tomorrow, sir. I will make it clear. Don't worry. Tomorrow will be the last day of
I will
confusion for
come
you.
tomorrow. I will come tomorrow and
So,
we'll clear it.
yeah.
I can
Sarita,
assure you of Rotary's full support. Full
I
support
I
in
don't
this
have any
endeavor.
doubts, sir. You guys are
Like we did polio, Rotary. In general, the discussion is that we have to do something about this, and
Sarita.
we
Your
have to
one
ensure that
point.
India becomes
Uh,
cervical cancer free.
Get yourself vaccinated and get screened. And we urgently need a change in the existing cervical cancer screening guidelines from national level.
Very rightly said. Very rightly said. Cherian Varghese, sir. Your one point of advice.
Stick to evidence. I think a lot, it's a very
Yes.
volatile field. So stay grounded on evidence so that we get the best out of everything. Thank you.
Yes. CP, your point of advice. One.
It will be mass scale awareness.
Okay. So, what about who all? Ritika, you have already become a teacher ambassador for us.
Thank you so much, sir. So basically, my advice would be that encouraging schools to work with pediatricians who can, pay frequent visits to schools. NGOs could be roped in, so that would create awareness.
Okay. Mank, your point of advice.
I think the cervical cancer presents itself as an opportunity for vaccination. I think they increase the vaccine coverage, and you are bound to take care of the problem.
Okay.
Because that is not the window we have with any other cancer per se.
Okay, Raj Lakshmi ma'am, your one point of action advice.
Yeah. I'd say that that cervical cancer, it provides an opportunity to strengthen public health systems and to focus on prevention rather have the emphasis on cure.
Okay. So, Shubham, your point of advice. One.
Yeah, so increasing more awareness, because it is not much of hesitancy that we see, but more of ignorance and lack of awareness about HPV vaccine. Often the
Okay.
old immunization cards are lost or torn, and parents may not be aware that some other vaccines which are optional, but they are pending. Increasing
Okay.
awareness.
Okay, Mary, your one point of action from Mary, are you there? Okay. So, I think Sachidanand sir.
So I think apart from the screening, vaccination, and treatment, we have to incorporate palliative care early in our
Yes.
practice.
Yes. I think now I'd like to call Deepak to give a vote of thanks. And thank you so much, everyone. And a big shout out for our resident who just made it possible in very short span of time. Deepak.
Thank you everyone for making it possible, even though we thought to do it at the last moments. Thank you, Her Excellency, for making her presence. On behalf of organizing committee, I thank all chairperson, speaker, Dr. Chiran Varghese, moderator, and all panelists. I thank all the participants for attending this event. I would like to thank ICGS, ICGCAN, and Dynamic CEO, Mary Aiken, for their engagements and participation. I would like to thank MOC and Borbag for their technical support. So thank you all. we will reach out to you for feedback and our activities. Thank you. And I
Thank
would
you
like to
so
thank
much.
Dr. Abhishek sir. Because of
Yeah, yeah.
him, this program made successful in just a
No,
short
I
span
think
of
it's a
time
combined
in 4 to
team
5
effort.
days. Thank you, sir.
Yeah, yeah. Thank you so much. So thank you again. And this is for Excellenciation. We have close to 100 people, even it is delayed by half an hour. So that needs. And with Dipanvita, Sarita, and Sweta, we need to have much more program. And you guys are the one who will decide the future of gynec-onc in India. So thank you so much for your active engagement. Thank you.
Thank you all.
Thank you. Thank you.
Thank you.